Stroke and Cerebrovascular Disease Lecture Series. I'm Stuart Fraser at the University of Texas, Houston. I'm very excited to introduce Dr. Heather Fullerton today, who will be our speaker. Dr. Fullerton is a pediatric vascular neurologist and clinical investigator at the University of California in San Francisco. After earning her medical degree at Baylor College of Medicine in Houston, she completed her residency, child neurology and vascular neurology fellowships and a master's in clinical research at UC San Francisco. She joined the UCSF faculty in 2003 and currently serves as the Kenneth Rainin Chair in Pediatric Stroke, Chief of Child Neurology, and the Medical Director of the Pediatric Brain Center at UCSF Benoist Children's Hospital. Dr. Fullerton's primary research efforts have focused on understanding the complex relationships between infection, inflammation, and arterial ischemic stroke in childhood. For more than 2 decades, she's held continuous NIH funding and led international multi-center prospective cohort studies in this area. And she also investigates hemorrhagic stroke in children, which accounts for half of all pediatric stroke cases, and directs the AHA Buger Center of Excellence in Hemorrhagic Stroke Research at UC San Francisco. She is also the principal investigator of the first NIH StrokeNet treatment trial for childhood stroke. Launched in February 2023, the Focal Cerebral Arteriopathy Steroid FOCUS trial is a comparative effectiveness study evaluating corticosteroids as treatment for focal cerebral arteriopathy of childhood, an inflammatory post-infectious arteriopathy that affects otherwise healthy children. Beyond her research efforts, Dr. Fullerton has been a leader in building global and national infrastructure for pediatric stroke. She's the founding president of the International Pediatric Stroke Organization, a nonprofit dedicated to advancing prevention, care, and lifelong outcomes for children with cerebrovascular disease worldwide. She also serves as a co-mentorship officer and executive committee member of the NINDS Child Neurologist Career Development Program, a national K-12 program committed to training the next generation of academic child neurologists. On a personal level, I'm really excited for her to be here. I am actually one of Dr. Fullerton's many mentees through the CNCDP K-12 program. She's an excellent speaker. She's very passionate about helping children with cerebrovascular disease. And I promise whatever field with neurology you work in, this stuff is high yield and can make a difference in the lives of your patients. So please give a warm welcome to Dr. Fullerton.
All right, thank you, Stuart. That was such a great introduction. I really appreciate that. So I'm very excited to be here today to talk about pediatric stroke, especially because yesterday was a really exciting day for us. So this is hot off the press. Some of you may be aware that the American Heart Association Acute Ischemic Stroke Guidelines 2026 version were published yesterday. And we are very excited in the field of pediatric stroke because for the first time ever, American Heart Association guidelines have included recommendations for pediatric stroke. And so this is a big deal to us. Get with the guidelines. That's an AHA quality program, really is dependent on guidelines and having pediatric stroke within those guidelines now is a huge thing for us. So very excited about that. So today I'm going to give a quick overview of pediatric stroke. So pediatric stroke is complex, as you might imagine. Then I'm going to focus on some things that are new and exciting in the field, and then finish with a little bit of a discussion about systems of care and pediatric stroke readiness. So not a new disease, as I think many of you know, but historically was quite under-recognized. And so this is a painting that Gabrielle de Weber showed me. She's a founder of pediatric stroke from Sick Kids in Toronto. And this painting was called The Boy with a Club Foot. But if you look at the upper extremity involvement, you can see that it's not, this is not just a club foot. And in fact, if you look at this kind of pattern of weakness, this actually looks quite like what we see in kind of modern sort of diagrams of hemiplegic cerebral palsy. And so hemiplegic cerebral palsy, really hemiplegic cerebral palsy, is basically a disorder caused by brain injury to the motor cortex on the contralateral side. And a perinatal stroke or a very early childhood stroke is going to be the most common cause. And so just to kind of set that in your mind, we still hear a lot of even physicians say that they didn't know that children can have stroke. But of course, people are familiar with the concept of cerebral palsy. So the modern era of pediatric stroke really began with advances in neuroimaging in the 1990s. And so with the advent of T2, we could visualize cytotoxic and vasogenic edema. With diffusion-weighted imaging, we could detect acute infarcts. And then MRA really allowed us to visualize arteries without exposing children to contrast and invasive procedures like conventional angiograms. And so because people were reluctant to do more invasive studies in children, having these non-invasive techniques, these techniques that did not expose children to radiation, really revolutionized the field of pediatric stroke. And so the literature on pediatric stroke really started to emerge in the late 90s with the advent of this type of neuroimaging. And so with better diagnosis, of course, there was increased recognition, and there were some early epidemiologic studies in the 1990s that kind of shared like a few fundamental concepts. So it is a rare disease, but it does happen. So it affects about 5 per 100,000 children per year in the U.S. and likely higher in developing countries in particular, because some of the risk factors that we'll talk about in a minute. And then the other important thing that emerged with some of these early epidemiologic studies was the fact that children more commonly had hemorrhagic stroke. And so when you think of stroke in adults, the vast majority are ischemic stroke, and only about like 15% of the strokes in adults are hemorrhagic, fortunately, since those often have a poor outcome. But in children, we actually see that about half the strokes in childhood are hemorrhagic. And in fact, the outcomes after hemorrhagic stroke in children can be quite good. And there's some suggestion that the outcomes after hemorrhagic stroke might even be better than ischemic stroke in children. So that was a really important difference. We also kind of in work that we were doing like in the early 2000s sort of started to address even like what ages are at risk for stroke. And so we realized that certainly the first year of life was a period of higher risk for both ischemic and hemorrhagic stroke, but especially the perinatal period. And so this is truly the highest period of risk for stroke in an individual's lifetime when you think about it, because this is a stroke risk that's happening right around the time of birth. And on that particular day, when a baby is born, there's about a 1 in 1,100 chance of suffering from a stroke. And so we call perinatal stroke strokes that happen anytime from 20th week of gestation to 28 days of life. These can present acutely in the neonatal period, most commonly with neonatal seizures, sometimes also just with encephalopathy, where the babies are sleepy, they're not feeding very well. But oftentimes an acute ischemic stroke in the perinatal period won't be recognized. And maybe that baby will be a little bit sleepy, but then their feeding kind of picks up and they carry on and never get any head imaging. And then they might present basically later in infancy as they start to develop voluntary control of their extremities. So kind of at that age, 4 to 6 months, when babies are starting to reach for things, grasp things, then that's when you can see a pathologic early-handedness. And so babies should not actually become right-handed or left-handed until closer to 2 years of age, but certainly before 1 year of age, that's considered pathologic. So these delayed presentation of perinatal stroke will often manifest just with this pathologic early handedness. And so the hand that's affected by this stroke is often fisted, as you see in this picture of this little girl whose left hand is fisted, suggesting that she probably had a right middle cerebral artery stroke. And so middle cerebral artery strokes are the most common pattern of strokes that we see in this perinatal period. The pathogenesis of perinatal strokes still remains somewhat obscure. Often we don't find a specific etiology, but we do know that a lot of the risk factors for perinatal stroke relate to essentially inflammation in the placenta. And so maternal fever is a risk factor, prolonged rupture of membranes, chorioamnionitis, also preeclampsia, risk factors for perinatal arterial ischemic stroke. And so these things are probably related to inflammation in the placenta, blood clots that are forming in the placenta, and then traveling to the baby. One thing that we learned relatively early on, kind of in our journey of trying to better understand pediatric stroke, was that fortunately, the risk of a recurrent stroke after neonatal stroke was very, very low. And so essentially, if a neonate has a stroke, it's thought to be, again, related to things in the placenta. Once the baby is born, they're outside of that kind of risk state, and their risk of having another stroke is very low. And probably their risk in most cases is going to be similar to any other child. And so it's the older children, and this is just like an old study that we did in the early 2000s where we were just looking at risk of recurrent stroke. And so here are the older children, and you can see that at the start, none of them have yet had a recurrence, but then these recurrences are happening in that first year of life. And overall, about 20% of children were having recurrent strokes. But in the neonates, it was very, very rare. And so the one exception might be a child, an infant, with a structural heart disease, so complex congenital heart disease that might have a stroke in the first month of life and be at risk for a recurrent stroke. But the strokes that are happening right around the time of birth, around that time of delivery, those babies, once they're born, they're not at risk of having a recurrent stroke. So if you look then at the research in perinatal stroke, most of that research is really focusing on neuroprotection and also on recovery. And so there have been a lot of advances in the understanding of mechanisms underlying newborn ischemic brain injury, both global injury like birth asphyxia and focal injury like an arterial ischemic stroke. Therapeutic hypothermia has emerged as this effective therapy for global HIE, so this birth asphyxia and a global ischemic injury. A lot of these hypothermia trials enrolled babies with neonatal encephalopathy. Perinatal stroke is also a cause of neonatal encephalopathy. And so there are probably some perinatal strokes that are benefiting from treatment with therapeutic hypothermia. And now there are kind of a lot of ongoing efforts looking at possibilities for enhancing recovery and function. And so some of our colleagues in Utrecht are working on investigating the role of mesenchymal stem cells to basically improve neurorecovery in babies with perinatal stroke. And then Stuart, who introduced me, he's very involved in neurorecovery and the use of brain-computer interface technology that hopefully will provide more opportunities for kids to have improved recovery. And some of this perinatal work, neurorecovery after perinatal stroke, has been done in Calgary by Adam Curtin. I'm now going to focus on childhood stroke, so kind of putting the neonatal stroke behind and focusing on older children. And I have to start by saying when it comes to childhood stroke, most kind of stroke alerts in children end up being mimics. And so stroke mimics are vastly more common in children than stroke itself. And so various studies have shown different ratios, but it generally ends up being about 9-to-1. Which is a major challenge for pediatric stroke pathways. And so the most common mimics are going to be migraine, so migraine with aura, so a child that will have a focal neurologic deficit from migraine, Seizure with postictal TODS is the other big one. And then rarely we see things like brain tumors where the edema around the tumor suddenly affects the motor cortex and they'll present with an acute hemiparesis. And then some other very sort of rare things like mitochondrial disorders like MELAS that will present with focal neurological deficits, or certain chemotherapeutic agents like methotrexate can be a stroke mimic. Unfortunately, it's really hard to clinically distinguish between a stroke mimic and a stroke. And I'll say a little bit more about why that is. But the bottom line is that pediatric stroke pathways, where we're trying to increase our early recognition of childhood stroke, really depend on MRI scans to rule out mimics. Can still get a CT scan to detect a hemorrhage. And as I mentioned, half of the strokes we see in children are hemorrhagic, but it's not enough to have a CT scan that shows no presence of hemorrhage to then clinically diagnose an arterial ischemic stroke in a child. We really depend on MRI scans to make that distinction. And so when we think about stroke presentation in children, here I have a little table that I put together showing presentation for arterial ischemic stroke, venous sinus thrombosis, intracerebral hemorrhage, subarachnoid hemorrhage. There's a lot of commonality with what we expect for adults. So hemiparesis, an acute onset hemiparesis, is the most common presentation of an arterial ischemic stroke in a child. And certainly headaches are very common with hemorrhagic strokes. And so thunderclap headaches that we see in adults with subarachnoid hemorrhage in particular. We also see these really abrupt, severe headaches in children with hemorrhagic stroke. But there's some challenges that we have. And so one problem in children is that the hemiparesis is often stuttering or kind of insidious in onset. This probably relates to the fact that children have better peel collaterals. Another problem that we have is that children will often have headache at their stroke ictus, even with the ischemic strokes. And so with that, we often see that children will initially be mistakenly diagnosed with a migraine with aura. So any child presenting for the first time with a migraine with aura, a headache followed by a focal deficit, really has to be considered a stroke until that's ruled out, because often clinically you cannot tell. And part of why you cannot tell clinically is because the kids who most often get headaches with their ischemic strokes are kids that have migraine genes, not surprisingly. So you ask for a family history of migraine, there's often a family history. You ask for migrainous features like photophobia, you often will elicit migrainous features to the headache. And that's because an ischemic stroke just triggered a migraine in that child. So you cannot really rely on history to be comfortable that a focal deficit preceded by a headache is a migraine with aura. And likewise with seizures and the diagnosis of postictal TODS, children simply have a greater tendency to seize. And so a seizure at the stroke ictus is very common in children, whether it's an ischemic stroke or a hemorrhagic stroke. And so this again leads to misdiagnoses of postictal TODS. A child will have a seizure followed by a focal deficit. People will conclude it's a postictal TODS, but really it was that the stroke triggered a seizure. And so again, you really cannot make a diagnosis of migraine with aura or a postictal TODS without doing the imaging to rule out a stroke as the trigger for that headache or that seizure. Fundamentally, when we think about childhood arterial ischemic stroke, it's kind of the same as arterial ischemic stroke in adults. We have an occlusion of a cerebral artery, we have an infarct in an arterial distribution, and it manifests with neurological manifestations. So same fundamental mechanisms, but certainly different etiologies, and then also different recoveries. Our understanding of etiologies and pathogenesis has improved a lot since when I entered the field now, like 25 years ago. And so at the time that I started looking into pediatric stroke, when I saw my first pediatric stroke, you would see this literature of kind of like some hospital case series that would just sort of describe these sort of like long lists of etiologies or risk factors. People would use it very interchangeably for pediatric stroke. And there was a big emphasis on hypercoagulable conditions because the hematologists were actually active in this space before we were as neurologists. And so there is a role for thrombophilia in the pathogenesis of pediatric stroke. But this laundry list was definitely very much of an oversimplification. And a lot of childhood strokes are probably heterogeneous in their causes. Also difficult to classify and often multifactorial. And so in many cases, there seems to be some component that probably is genetic, some sort of underlying susceptibility, some rare Mendelian disorders, but a lot of these are not Mendelian, but presumably some sort of polygenetic predisposition to childhood stroke, combined with some sort of role of the immune system and inflammation, and then environmental triggers. And so just to give you an example of this, congenital heart disease likely is also genetic at some level in its basis, probably polygenetic and complicated. But you have this predisposition to childhood stroke if you have congenital heart disease and a structural abnormality of your heart. And then you add on to that a fairly common hereditary thrombophilia. And then that child basically is existing, perhaps going to school. They've got their underlying structural heart lesion. Maybe it's been partially treated or even completely treated. They've also got a hereditary thrombophilia that maybe they didn't know about. And then they get a cold. And with that cold, that viral infection, it basically triggers an inflammatory process that then acts as a trigger for a stroke in this child. And so there's literature to support that among children with congenital heart disease, it's those that have some coincident hereditary thrombophilia that are at greatest risk for a stroke, and then infections are acting as triggers in those children. Certainly also procedures act as triggers in these children. And so we also see strokes around the time of cardiac catheterizations and cardiac surgeries. But in the child that's at home with their congenital heart disease, often it's infection that's acting as a trigger. And similarly, arterial dissection. So a lot of these kids will have some minor collagen abnormality. There's literature on kind of like increased prevalence of hyperextensible joints in patients with dissections. So they probably have some sort of genetic predisposition. A recent infection might again make those vessels a little bit more susceptible, and then you throw in some minor trauma. And so a lot of the dissections that we do see in kids probably represent this kind of perfect storm of different factors coming together, because the majority of dissections are not happening after major trauma, like a motor vehicle accident. Most of the ones that we see in kids are either spontaneous, where there's no trauma, or often there's some sort of minor trauma, like just falling on a basketball court or diving into a pool with no trauma to the head or neck, and so kind of activity associated. So in general, we do still try to kind of put arterial ischemic stroke into a few different buckets. And so the literature that's kind of emerged over the past couple decades suggested that cardioembolic strokes, which we used to kind of consider a major factor, probably represent just about 20% of all the strokes that we see in children, and we're overrepresented in older literature just because of the bias of referral centers and centers with big congenital heart disease programs. About half of the strokes that we see in kids are arteriopathic, so due to some sort of cerebral or cervical arteriopathy, and I'll say a little bit more about that. And then surprisingly, even today, about 1 in 5 kids will undergo a big workup for the cause of their arterial ischemic stroke, and we do not find one. And so about 20% of the time, the strokes that we see in children are idiopathic, which seems a little crazy. A healthy child has an arterial ischemic stroke, sometimes a major one, and 1 in 5 cases we do not find a cause. So the one good news, if the stroke is idiopathic, is that if a child really has normal vascular imaging, their neck vessels look normal, their cerebral vessels look normal, they don't have an underlying congenital heart disease either that would have thrown a clot and occluded a vessel, those are the kids that have the lowest risk of having a recurrent stroke. And it's really the children with the arteriopathies that are at highest risk of recurrent stroke. And so for this reason, and this was from an old study, but multiple studies since then have kind of shown this over and over, that the presence of an arteriopathy is the major predictor of having a recurrent stroke. And so for this reason, we have focused a lot of attention in pediatric stroke research on these pediatric arteriopathies. In general, I like to think of them in kind of 2 categories, the acute cerebral arteriopathies and the chronic ones. And so the chronic ones are things like moya disease or syndrome. And so this chronic, slowly progressive, occlusive disease of the distal carotid and its proximal branches. Sickle cell arteriopathy falls into that category, although sometimes it's outside of the moya picture. Radiation arteriopathy, where kids have been exposed to radiation for treatment of their brain tumors. And so these chronic ones present a little bit differently. They're more likely to present with TIAs in addition to ischemic stroke, or just headaches, cognitive impairment, or they can even be asymptomatic and found on screening. The acute cerebral arteriopathies are different. So arterial dissection, which you'll be very familiar with from adult stroke, if you come from that background, vasculitis secondary to meningitis. So something that we're seeing more again for some reason, where with bacterial meningitis, even in kids who are vaccinated against things like pneumococcal and HIV, we're seeing occasional cases of bad bacterial meningitis recently, and kids can get a really severe vasculitis from that, as these cerebral blood vessels are getting surrounded by pus, which is so inflammatory. And then the other one is focal cerebral arteriopathy, which is a more unique childhood disease that I wanted to spend a little bit more time on. But in general, the acute arteriopathies tend not to present with TIAs or some of these other things that a chronic arteriopathy will present with. They tend to present with acute ischemic strokes. And maybe occasionally there's one that's asymptomatic and we diagnose it incidentally in a delayed fashion. The most common arteriopathy in previously healthy children is something that we call focal cerebral arteriopathy. And this seems to be almost a uniquely pediatric disorder, although there's some evidence that it might occur in some young adults. These are mostly school-age children, but we've seen it in toddlers to 18-year-olds. And they usually present with a hemiparesis from a lenticular striate infarct. And it seems to be this inflammatory disease of the distal carotid and its proximal branches. And so here is like an angiogram of a case of focal cerebral arteriopathy. We rarely get cerebral angiograms in these kids anymore, but you can see that this is the proximal middle cerebral artery, and it has this kind of funny banding to it that probably is an indication of inflammation in the wall of this vessel. The MRA at this point might actually be normal or just have some subtle irregularity, but you have these little lenticular striate arteries that are coming off of this inflamed vessel that probably get occluded by this inflammatory process. And so that's why they will typically present with a lenticular striate infarct. But what's so frightening about this disease is that it can progress really dramatically over a course of days, often with extension of the infarct or more infarcts. This is a disease where, like here you can see at baseline, this is like the M1, and this is like a case from our VIPS cohort study. And you can see that like this M1 looks a little raggedy, a little bit irregular, but the lumen definitely looks like it's quite open. And then a matter of days later, you can see this sort of string sign here, where this vessel has gone from basically a near normal lumen to a really high grade stenosis. And this, again, often is associated with additional ischemic brain injury. This is a funny disease. It remains unilateral. It never spreads to the other side. It's monophasic. It does not recur, and it's sporadic. It doesn't run in families, but it is often triggered by infection. And so Stuart mentioned that infection as a trigger has been one of my major research interests. And so this disease has been something that I've been really interested in. So what could possibly cause this disease? It's unilateral, monophasic, often preceded by an infection. Most of these infections are upper respiratory infections, including COVID-19. But in the past, a lot of the cases that we saw of FCA were actually preceded by chickenpox, which gives us some potential clues to the pathogenesis, because you guys will remember that herpes viruses remain latent in the trigeminal ganglion, and here's the trigeminal ganglion here. Here's the internal carotid artery. They're very close to each other anatomically. And the trigeminal nerve actually innervates the intracranial arteries. And so I started working with this wonderful pediatric infectious disease doctor, Dr. Gross at University of Iowa, who specializes in herpes viruses. And he actually dug into some old literature that basically showed how and where the trigeminal nerve innervates intracerebral arteries. And it's interesting because the pattern of trigeminal innervation actually parallels the vessel involvement in focal cerebral arteriopathy. So that's led Dr. Gross to postulate that FCA after chickenpox might actually be a form of shingles, but instead of like the particles of virus traveling out to the skin and causing inflammation, they're traveling inwards towards these blood vessels. And this just shows from this primate study, the black is where the most innervation of the trigeminal nerve is located. And so it really kind of parallels the pattern that we see in focal cerebral arteriopathy, and might explain why it would be unilateral, because if you just have unilateral involvement of the trigeminal nerve, it could explain a unilateral arteriopathy. So that's kind of a very quick overview, some background about pediatric stroke and sort of the work that's been done over the past couple decades. But now I really wanted to focus on kind of like what's new and exciting like this year in the field of pediatric stroke. Like what are people talking about in the field of pediatric stroke? So one is, as Stuart mentioned, our first pediatric stroke treatment trials have launched. And so I just told you about focal cerebral arteriopathy. And the question with this presumed inflammatory disease is whether immunosuppressant therapy can help to intervene and prevent that really rapid disease progression that we can see that's associated with more infarcts. And so here in the US, we're doing the FOCUS trial, which is a StrokeNet trial. And so we're doing this in the context of the NIH-funded Stroke Clinical Trial Network. And then in Europe, our colleague Maya Steinlin is leading the PASTA trial. And so the pediatric arteriopathy steroid aspirin trial, and that's a multi-center study in Europe, Australia, and now they also have some sites in India. Our trial is a comparative effectiveness trial. So interestingly, the Europeans started using steroids for focal cerebral arteriopathy and actually changed practice such in the US that people were unwilling to randomize these kids to no steroid therapy at all. In Europe, though, they're actually randomizing to steroids or placebo. And so PASTA is actually a true RCT that will test the efficacy of steroids for FCA. FOCUS, we ended up having to design as a comparative effectiveness trial that really examines timing of steroids. We're often not sure of the diagnosis of FCA until we see that rapid disease progression. So the question is, should we just go ahead and treat with steroids when a child comes in with a lenticular striate infarct? We think maybe they have focal cerebral arteriopathy, but we're not sure. Should we just give steroids knowing that we'd be kind of over treating and giving steroids to some children that turn out not to have FCA? Or should we wait until that child has kind of the characteristic disease progression that's diagnostic of FCA and then start the steroids? So that's the design of the FOCUS trial. But we did plan a meta-analysis prospectively a priori with Maya Steinlin in Europe. And so we'll be able to leverage the control data that they're prospectively collecting in their trial. So very excited about that. And I'm grateful to some of our colleagues who I know are on this who have been enrolling cases. We've seen an interesting geographic distribution in this trial that we haven't seen previously, where we've had a lot of cases in the South and Southwest. And so we've now enrolled like 27 cases, and all of our cases have basically been Texas, Arizona, Utah, California, Oregon, and Washington State, and nothing in the Midwest or Northeast. So really interesting that we're seeing this. And thank you to all the Texans who have been helping with this trial. Very appreciative. So another kind of new thing that we're talking a lot about in the field of childhood stroke is endovascular thrombectomy. So you guys all know that these trials came out 2015, 2017, 2018, new trials showing very robustly that removing an acute clot from a large vessel occlusion in an adult is effective at improving outcomes. None of these trials included children, always excluded. But what we found was that subsequent pediatric observational data, especially this SAVES Child Pro study, a multi-center, multinational trial that's been led by Peter Sporns in Germany, suggests that these children are benefiting from endovascular thrombectomy. And so what we can see, and so I'll just kind of break this down a little bit, but you guys probably are familiar with these sort of shift analyses that we see a lot in adult stroke trials. And so here are the kids that got best medical treatment. So these are all kids that had large vessel occlusions with acute strokes. These kids, 91 kids, best medical treatment. These kids were treated with endovascular thrombectomy. And when you think about it, who's most likely to get endovascular thrombectomy? So off-label, like this is not an approved therapy for kids. So when it was being offered, we were offering it to kids with more severe deficits, so kids with more significant occlusions. So being in this group, it basically was biased towards more severe cases, and the data in this study does prove that these are the more severe cases that were getting treated. But even with that bias towards this group being the more severe cases, this group that got the endovascular thrombectomy actually had a greater rate of good outcomes. And so these lighter bars then represent the kids with good outcomes with full recovery over here, and the kids with severe deficits over here. And you can see that these kids are shifted towards having better outcomes, even though they were worse off to start with. And they also did a propensity scoring analysis that, again, kind of matched the kids based on the severity of their initial stroke and their initial LVO. And again, you see that the kids that got EVT seem to benefit. So because this is actually quite strong evidence, this is actually what led to children being included in this new guideline. And so for anybody who joined late, I mentioned at the beginning of this that just yesterday, the American Heart Association released their new 2026 guidelines for acute ischemic stroke. And for the first time ever, children are included in those guidelines. So we now officially have guidelines for the management of acute ischemic stroke in children. And there's actually a whole set of guidelines about considering endovascular therapy for children that certainly in children that are greater than 5 years of age. And so I think this is really going to be transformative for us. A lot of pediatric stroke centers have been doing this, and now we're really going to need to partner with primary stroke centers to make sure that children who are in this age range, like 6 to 17, are being considered for endovascular thrombectomy if they have a large vessel occlusion. Still less clear what should be done with the younger kids, in part because they're more likely to have a good recovery from their arterial ischemic stroke. But the guidelines now actually give us something to go on instead of just kind of everybody doing their own things. So what about thrombolytics? We're still in a really weird place with thrombolytics. So that's why, like, here I'm like, new, we have something new and exciting. Here we don't really have anything new or exciting. Some of you may know that there was an attempt to study TPA in children now more than 10 years ago, the thrombolytics in pediatric stroke trial. That was not a successful trial. It was closed due to failure to enroll. That was largely related to Peel collaterals in kids, and the fact that kids' Peel collaterals would come in, their NH stroke scale scores would drop and they would become ineligible, even though Peel collaterals aren't necessarily sustainable in kids and they can fail later. In any case, that trial closed, but since then there's been a fair amount of observational data that suggests safety. We still don't actually know appropriate dosing for even TPA. There are some dosing guidelines for TPA for other indications in children, at least. So we at least have that. So things like line occlusions, for example, but we don't have specific weight-based dosing for a pediatric stroke indication. And if anything, the adult weight-based dosing may be insufficient in younger children, because it's tissue plasminogen activator, and younger kids have relatively lower levels of tissue plasminogen. And so I think that speaks towards safety. It's probably safe to use it in these younger kids, but we may actually be underdosing them. TNK presents a whole new challenge to us. TNK has not been studied in children at all. And so we don't even know how to dose TNK in children. So TPA, at least we have some dosing like PK/PD data for other indications, but TNK, we don't even have PK/PD dosing. But yet now, everybody who's involved in adult stroke knows that TNK has really become the leading antithrombotic for acute stroke in adults because of the ease of administration. Fortunately, though, the FDA actually requires somebody is not on mute. Could everybody just check unmuted? Tarina, I think maybe you need to mute because some noise is coming from your microphone. So TNK definitely presents this challenge for us, but the FDA has required a pediatric trial as a post-marketing requirement. And so this is great news for us in pediatric stroke. For TPA, the FDA gave a waiver saying that it was infeasible to study TPA in childhood stroke. But in this current era, the FDA decided not to give a waiver and is actually requiring this. So, the makers of TNK, Genentech, Roche, are working with us and with StrokeNet to design a pediatric trial to meet this FDA requirement. So we're very excited about that. But in the meantime, thrombolytics are addressed in a very limited form in this new set of guidelines that I mentioned. And so basically now there are guidelines that specifically say that for children that are presenting within 4.5 hours with an acute arterial ischemic stroke, that alteplase, so not tenecteplase, but alteplase TPA may be considered as safe, but efficacy is uncertain. So at least we have that to now give us some guidance that it's reasonable to give alteplase. But of course, this now represents a challenge as most stroke centers are prepared to give tenecteplase. So more to come on that whole story. I just want to quickly mention a few other places where there are advances. So new genetic insights into moyamoya disease, like the primary form of moyamoya with RNF213 is this really interesting susceptibility gene. RNF213 is interesting because it's important in innate immune function. And so, again, there's this connection with exposure to infection and sort of a thought that these genetic variants might predispose somebody to moyamoya, and then certain infections might actually act as a trigger to develop the disease. So really interesting, and perhaps this new information, new genetic information, will actually lead to some therapies that can halt the chronic progression of this disease. Because right now, we basically just rely on antithrombotics and surgical bypass, but we're not doing anything to actually prevent that arteriopathy progression. I always want to comment on sickle cell disease. It remains the most common cause of childhood stroke globally. Historically, a very high cumulative incidence of stroke in people who have sickle cell disease if they're not getting any sort of primary stroke prevention. And this basically just shows the proportion of people with sickle cell disease. And here's hemoglobin SS, so sickle cell anemia as opposed to SC. So the proportion of people with sickle cell disease who remain stroke-free, you can see that that's just diminishing over childhood through young adulthood. So very, very high rates of stroke in sickle cell disease. The story of stroke prevention in sickle cell disease is probably like the greatest success story in pediatric stroke. And this was work that was led by Bob Adams in the 90s. And so we do have a primary prevention strategy where we can detect kids at high risk for stroke using TCDs. They can be treated with monthly blood transfusions. Hydroxyurea is a good alternative, but this remains extremely difficult to execute, even in resource nations like ours, but especially in low-resourced nations where hydroxyurea, which costs like only cents a day for each pill, it's like 18 cents or something like that at some point. It remains inaffordable for a large part of the global population of patients with sickle cell disease. Just want to quickly touch on hemorrhagic stroke. So most of the hemorrhagic strokes that we see in kids are due to underlying structural lesions, unlike the hemorrhagic strokes that we see in adults. So especially arteriovenous malformations and cavernous malformations is a couple of the most common causes. And right now, brain AVMs are treated by surgery or gamma knife radiosurgery. We don't have medical therapies, and not all AVMs are treatable because they might be in a really eloquent location or they might be really large and diffuse. But new research on AVM genetics is kind of leading to novel therapeutic options that are now being explored for these kind of untreatable lesions. And so this just kind of quickly sort of shows some of the genes that are thought to be involved in the pathogenesis. And these are somatic mutations mostly, so mutations that are occurring after conception. And these MEK inhibitors, KRAS inhibitors, PIK3CA inhibitors, like these are now being tried as potential therapies for vascular malformations that are not otherwise treatable. So more to come on that. And then also super exciting. So we see AV fistulas in kids that are totally different from the AV fistulas in adults. They're congenital. They're PEEL, meaning blood vessels to the brain, are the ones that are involved in these fistulas. And vena-Galen malformations are these kind of really large and very devastating congenital arteriovenous fistulas, can cause a lot of brain injury, even prenatally. So these remain a major challenge. And now Darren Orbach at Boston Children's Hospital is leading a new fetal treatment trial where he's actually treating these lesions, doing initial treatment of these lesions prior to birth, because things tend to really go downhill after birth when the child goes from a fetal circulation into a mature circulation pattern. So really exciting kind of new therapies now for vein and Galen malformations, thanks to Darren Orbach. And so if you know of patients like this, he is recruiting patients. The families fly to Boston to get this prenatal therapy done, but only for select patients. So definitely good to know about those. So in these last few minutes, I just wanted to address systems of care. So childhood stroke has historically fallen into a gap. We've developed all of these really robust stroke centers in the US, our comprehensive stroke centers, our primary stroke centers, our adult stroke pathways, guidelines, the American Heart Association Get With The Guidelines, very robust. But on the other side of this kind of gap is children's hospitals and pediatric pathways and providers. And there's often a big disconnect where children's hospitals aren't so familiar with kind of Get With The Guidelines and adult stroke processes. And a lot of stroke centers aren't really thinking about children with stroke until they're confronted with children with stroke. And I have an example of like a particular small city where they had kind of decided that there were two health systems and they were going to kind of divide things up. And one health system was going to do all the complex pediatric stuff. The other health system was going to do the complex stroke care, among other things, as they kind of divided up their care. And then the child of a physician actually had a stroke. And they didn't know how to take care of the child because the child went to the children's hospital, but nobody at the children's hospital was able to do thrombectomy. The people at the Comprehensive Stroke Center didn't have privileges at the Children's Hospital. The Comprehensive Stroke Center wasn't equipped to take care of an 11-year-old child. No pediatric anesthesiologist. They weren't even certified to take care of children. So it brought out a real gap in a system of care that led to a child with an LVO at 11 years of age not being able to get treatment for that LVO. And we still face the challenge that that childhood stroke is still quite under-recognized, but yet we now have tools that can help us reduce mortality and morbidity and also help us to prevent recurrent stroke. Previously, all we had in terms of AHA statements about childhood stroke was a scientific statement, and the level of evidence at the time of that scientific statement was thought to be inadequate to justify an actual guideline. That was in 2019. So really big deal for us that now in 2026, we have for the first time ever this set of guidelines that addresses pediatric stroke within this larger set of acute ischemic stroke guidelines. And then also IPSO has published first ever guidelines for pediatric hemorrhagic stroke, since that's been such a gap. There are steps to pediatric stroke readiness, awareness, making sure the emergency department is aware that strokes happen in children, recognition, setting up systems to do that MRI scan to diagnose the stroke in a child, and then care pathways that include kind of like rapid assessment of the neuroimaging, and then pathways to provide acute treatment, and making sure that pathways for endovascular therapies in particular are available to children within a city, within a region. And so we're really excited that these American Heart Association guidelines will help us. The Brain Attack Coalition that IPSO is part of is working on new primary stroke center guidelines that will also include pediatric stroke. And these guidelines have pediatric stroke kind of sprinkled throughout these new guidelines, so including recommendations for the emergency evaluation and recommending that children do get emergently evaluated for a stroke. And there's some additional imaging recommendations in the guideline as well. We have some tools. The American Heart Association has a few things that are coming out soon that I recently helped them with. So a pediatric stroke readiness infogram, a pathway, and then IPSO has already developed a pediatric stroke readiness checklist that's available on the resources page of our website. And so that's available, and we've been doing a lot of work. And so I think the pediatric stroke people who I know are on this Zoom, I think we're going to get a lot more requests for help from various primary stroke centers to help them prepare for childhood stroke now that it's part of the American Heart Association guidelines. So detection is possible. Now we have guidelines. Etiologies are different, but still we think some of these acute therapies can be used in kids. And so it's really time for the pediatric stroke community to work with primary and comprehensive stroke centers and make sure that we're all ready to help these children with stroke. That's it. So thanks you guys for your attention. I really appreciate it. Very exciting to actually be here talking about this the day after those guidelines were released. I had to do a lot of work updating my slides this morning after the guidelines came out yesterday, but I'm happy to take any questions. Oh, and I see that there are, oh yeah, so there's a question in the chat. What is the number of ischemic strokes your program sees per year and how many undergo thrombectomy? So it's still very rare, and this is part of the challenge. So like our hospital at UCSF, we're a pediatric stroke referral center. We still see a handful of these a year and maybe treat like a couple kids with thrombectomy a year. So it's rare. It's basically, sometimes it feels like we're looking for needles in a haystack. But like with everyone that we do identify and we make that difference by treating that LVO in a child, we're making a big difference because that child is young. They have a whole lifetime ahead of them. And if you can reduce the degree of brain injury and reduce the disability, you're making a really big difference. So another comment, curiously, we now have a lot of detailed criteria for EVT and adult stroke. Yes, MEVO and NIH stroke scale score. Do we have similar criteria? So, so that's such a good question. And so there are so many unanswered questions, and the guidelines have left it a little bit loose. We do not want to exclude children with low NIH stroke scale scores. And so that was something that I think our pediatric stroke community has really discouraged because like in that TIPS trial, we see these kids that come in, NIH stroke scale score of 11, somebody puts their head above flat, gives them a fluid bolus, their peel collaterals kick in, and their NIH stroke scale score drops to 4. And then people think they're ineligible for therapies, even though they still have a large occluded vessel. We still think it's better to reopen that vessel. Peel collaterals can fail, just like in those cases of like that acute arteriopathy with FCA, they can extend their infarcts. So we do think that if they're within that time window, that it's better just to remove that thrombus. In your experience, what percentage of FCA worsen in the early steroid? In your experience, what the percentage of FCA that worsen and if the early steroid plays a role in preventing it? Yeah, so that's a really good question. Sometimes we give steroids early in FCA and we still see disease progression. So what does that mean? That's something that our trial will be able to answer. So on average, if you give it earlier, do you see less disease progression? So that's a really good question, and that's part of why we're doing this trial. And then I think Ali, Carol, you have your hand raised. Did you want to ask?
Yes, thank you very much for the amazing talk. It's just going to depend how much time do you have. So many questions.
Yeah.
Regarding systems of care, I do have two questions, one for endovascular therapy and one for system of care. System of care question is regarding blood pressure management. How strong data-wise we have for pediatric in terms of blood pressure management for acute stroke? And what would you recommend for blood pressure protocol of blood pressure management for permissive hypertension, pre-thrombolytic, post-thrombolytic, post-endovascular? What would you recommend for pediatric population?
Yeah, it's crazy because we're in such a data-free zone. So yes, we have no data on blood pressure. And so I think our general sort of approach here, where we just have our kind of consensus-based guidelines for how to manage blood pressure locally, it's basically we never do anything that would drop blood pressures. We are very mindful of, are we doing something iatrogenically that would drop blood pressures, like giving somebody sedative medications that might drop their blood pressures, for example. And then we will actually use pressors even to try to drive these kids towards some mild hypertension or at least high normal blood pressures. So especially when you're still dealing with like the acutely occluded vessel, I think after a blood vessel's been reopened, we basically just try to aim towards normotension. I think luckily kids don't have a lot of reperfusion injury. We don't see a lot of hemorrhage into infarcts. So in the absence of kind of strict blood pressure related evidence, I think luckily we probably can be somewhat liberal, but I definitely aim towards higher blood pressures rather than allowing them to get low. I'm more afraid of low blood pressures and extending infarcts than high blood pressures and the concern of hemorrhagic transformation after ischemic stroke. So I'm not sure that helps, but in general, normal to high normal to even mild hypertension is generally where I'm aiming in the absence of data.
Awesome. And, just my second question regarding LVO patient within like 4.5 hours to 24 hours, that, the guidelines mentioned for, for pediatric is they put like that, sentence like quote unquote salvageable ischemic penumbra. Is it the same as the adults or is it kind of different criteria?
Think so. I think it's different because the adult criteria, a lot of them kind of depend on defining the penumbra. And the penumbra in kids often appears smaller. However you want to measure penumbra, it appears smaller artificially because of those peel collaterals. And so to me, salvageable tissue is basically has this kid infarcted the whole territory of that vessel? So if they have an M1 occlusion, have they infarcted the whole MCA territory, or do they still have some salvageable tissue? And if they haven't infarcted that whole territory, then I usually err towards trying to remove that clot. So I do think that's a really important distinction, and that's like a challenge that we're going to be facing as we talk more about selection of patients for EVT. But to me, I worry that people are too conservative if they don't see a penumbra. Yeah. So I don't like using perfusion criteria. I like to do it clinically, and if that child looks too good for a complete MCA stroke, that means to me they have salvageable tissue.
Wonderful.
These
Thank you
are
very
really
much.
hard questions. Yeah, thank you for asking. And Ty Ching, did you want to ask a question?
Hey, thanks for the wonderful talk. I have a question follow in the focal cerebral arteriopathy. I think it's supposed to be monophasic. I was wondering, it's ever do you ever see those focal cerebral arteriopathy eventually evolve into a myometrial angiopathy? Since the two conditions they can happen the exact location of the carotid terminus, all having young people, do they ever evolve into myometrial type vasculopathy?
Yeah, it can be really confusing, but I think that they are truly two different entities with different time courses. So if we have a diagnosis of FCA that then later evolves into moyamoya, I think we missed the diagnosis and it was moyamoya all along. But I've never seen a child that has classic FCA with that really rapid disease progression over a few days, then kind of develop moyamoya later and develop contralateral involvement and things like that. But it can be confusing because even the FCA kids in the chronic phase, if that blood vessel doesn't reopen, when I say monophasic, it means kind of that acute inflammatory progressive period happens once, but it doesn't always resolve. The arteriopathy often can result in a severe stenosis that's now probably a lifelong severe stenosis. And they can develop kind of retic collaterals, like little jump collaterals that can be mistaken as moyamoya collaterals. And so occasionally you'll see kids in the chronic state after FCA referred for revascularization for unilateral moyamoya because those little collaterals can start to look kind of like moyamoya collaterals. But I think it really is a different disease. And when those kids with FCA get to that chronic state where they have those little collaterals, they're not having TIAs. So clinically, they have a different course too, because they tend to stabilize and not have TIAs in a delayed fashion. So if you see somebody with kind of like a chronic M1 stenosis with some RT collaterals, I would be really hesitant to revascularize if they weren't having like acute TIAs.
Yeah, thank you.
Okay, thank you. Yeah, starting to see the data on the use of PULF MRI in this population acutely. I don't know if Tony's still on and wants to say more about that, but a big question is, are there imaging strategies that we can use to identify these kids? And that definitely remains like a big question. I feel like we have yet to kind of hit on the right sort of perfusion imaging that's going to help us with patient selection, which is why currently I favor doing it more clinically, and clinically kind of like thinking about whether that there's salvageable tissue in the distribution of that occluded vessel. And then Marcella. So Marcella is a hematologist who knows a lot about kind of risks of hemorrhagic conversion. So yes, in Marcella, we don't have data on risk of hemorrhagic conversion if we were to do a thrombectomy in a child with a small penumbra per perfusion studies. But, you know, so far, like the limited data that we do have that's coming out of Peter Sporn studies do suggest that that risk is probably low. And so, you know, the good thing about those PL collaterals is that that tissue then is being nourished through PL collaterals, so they're not going to get a reperfusion injury. Their penumbra is smaller, and so that penumbra theoretically should then mean that they have a lower risk of reperfusion injury with kind of like reopening in a delayed fashion. So really important questions, but my guess is that that children actually are safer to remove clots in a more delayed fashion because they're good PL collaterals. So, oh yeah, thank you, Tony. Hyperfine swoop is a portable fraction of a Tesla MRI machine now being used in the stroke space for triaging. In pediatrics, this will be a means to get MRI in the EDs across the country. Wow, thank you. So I will definitely have to read about that. That's super interesting because yes, this is a challenge for us, the fact that these children need MRI scans. Occasionally, if there's a child that's like really at risk and you're kind of nearing the end of a window, we might then just go ahead and do CT-CTA to at least make sure that there's not a large vessel occlusion. But otherwise, and if there were a large vessel occlusion that matched with somebody's deficits, you might consider doing EVT. But it's pretty tough because of this prevalence of stroke mimics and even questions about whether something that looks occluded is acutely occluded versus chronically occluded. So more better imaging techniques will really be helpful for us. All right. Well, thanks for all the questions. I really appreciate that. Appreciate the attention and people staying over to talk more about pediatric stroke. So thanks again, everybody, for joining. Really appreciate it. And yeah, have a good rest of your day.